Good day, everyone, and welcome to Accriva Diagnostics webinar, which features our guest presenter, Dr. Josser Delgado, who will focus on the impact of using antiplatelet medications for the endovascular treatment of cerebral aneurysms and the potential benefits of antiplatelet testing to help better manage patient outcomes. Dr. Delgado has worked with Consulting Radiologists Limited since 2011 and practices at Abbott Northwestern Hospital in Minneapolis, Minnesota, as part of their Neuroscience Institute. He currently performs all aspects of interventional neuroradiology in his practice there. He completed his clinical fellowship in diagnostic and endovascular surgical neuroradiology with the Mallinckrodt Institute of Radiology at the Washington University School of Medicine in St. Louis, Missouri. Please join me in welcoming Dr. Delgado today as I turn the webinar over to him to share his experience in the use of antiplatelet therapy testing for neurointerventional procedures. Good morning, Dr. Delgado, and good afternoon to some of the rest of you.
Okay. Well, thank you for the opportunity to share our experience with the important topic, which is the antiplatelet therapy testing for patients that are undergoing neurointerventional procedures. So I'm a consultant for various companies, including Accriva Diagnostics. So as you all know, there has been an increasing number of endovascular devices for the treatment of the cerebral aneurysms that have been designed to be deployed within the peroneal arteries lumen. This has led to a marked increase in the use of very potent antiplatelet agents by neurointerventionalists to prevent thrombosis of the device as it endothelializes. There is an ongoing but somewhat diminishing controversy among neurointerventionalists regarding whether or not we should perform antiplatelet therapy testing prior to undertaking these kinds of procedures. The field is really split between those people who do not test, which are the non-testers, casual testers that test every now and then the people that test consistently, which we're called the testers. There are really many questions regarding this antiplatelet therapy testing. First of all is, which test to use, and if we're going to do the testing, where to perform it, when to do it, and particularly what is a safe range. There's also questions regarding how do you manage people who are clopidogrel hyporesponders? Do you increase the Plavix dose? Do you add cilostazol, which is a new drug that has been that's entered the arena now? And do we switch to prasugrel or ticagrelor? There's also the question of what to do about Plavix hyperresponders. Do you decrease the Plavix dose? And if such, by how much? VerifyNow is an assay that measures the degree of platelet reactivity after the stimulation of the P2Y12 receptor with ADP. And the results are reported in P2Y12 reaction units, or PRU, or PRU. A high PRU signals that there is a high degree of residual platelet reactivity, and this can lead to an increased risk of thrombosis. While a low PRU indicates that it's a low degree of residual platelet reactivity, and this can lead to an increased risk of bleeding. The ADAPT-DS study was completed in Europe, and it was finally identified an optimal therapeutic range that was 95 to 207 PRU in over 8,000 patients that underwent coronary intervention. And our group has been proposing an acceptable PRU range of 60 to 240 for the last 3 years now in patients that are undergoing endovascular treatment of cerebral aneurysms with flow diverters and stents. There's a growing body of literature that has been specific to neurointerventional procedures that indicates that there is a very high degree of variability in response to the standard 75 milligram daily Plavix dose, and also that an increasing use of very potent P2Y12 receptor antagonists, such as prasugrel and ticagrelor, may be associated with an increased risk of bleeding in the perioperative period. These are all studies that have been completed in the neurointerventional literature going back to 2008, and this is specific to neurointerventional brain aneurysm treatments as well as stenting. And the majority of studies have come to the conclusions that there is a very strong correlation between the PRU values and clinical events, where a hyperresponse to Plavix can be associated with bleeding events, as well as a hyperresponse to Plavix can be associated with thromboembolic events. And on May of this year, we finally have a randomized controlled trial that has examined whether or not tailoring the dual antiplatelet therapy for patients who are undergoing brain aneurysm treatment can lead to improved patient outcomes. This was a randomized controlled trial started with 386 patients, but in the end we assigned 126 patients were high on treatment on platelet reactivity, and of those 126 patients, 63 were randomized to the standard preparation group, and the other 63 were randomized to a modified preparation group. The standard antiplatelet preparation consisted of the usual 75 milligrams of Plavix and 100 milligrams of aspirin. And the patients had to be on this preparation for at least 6 days. High on-treatment platelet reactivity was defined as a PRU value that was greater than 213, or an aspirin reaction units value that was greater than or equal to 550 ARU. The modified antiplatelet preparation for patients that had high on-treatment platelet reactivity to aspirin, the aspirin dose was increased to 300 milligrams, and the Plavix dose was kept the same. For patients that had high on-treatment platelet reactivity to Plavix, the Plavix dose was kept the same, and the aspirin dose was kept the same as well, but they were 200 milligrams of cilostazol was added to the patient. Cilostazol is a medication that cannot be given by itself, but it can potentiate the effect of Plavix on the platelets. The primary outcome of the study was the rate of thromboembolic events during the early periprocedural period, and that was defined as within 7 days after coil embolization. And this included any intraprocedural thromboembolic event, any transient ischemic attacks, or any ischemic strokes that happened within those first 7 days. Secondary outcomes included bleeding complications within the first 30 days after the coiling, or delayed thromboembolic events that happened from 8 to 30 days after the coiling. This is one of the summary tables from the study, and we can see that the majority of patients had aneurysms that were located in the internal carotid artery. And importantly, the majority of patients also underwent stent-assisted coiling. So this is really an internal carotid artery stent-assisted coiling study. With the results, we see that of the patients that underwent the modified preparation as a result of the dual antiplatelet therapy testing, the thromboembolic event rate was 1.6%, with a bleeding event rate of 9.5%. The patients that underwent the standard preparation, the thromboembolic event was much higher at 11.1%, with also a certain risk of bleeding events of 6.3%. So modifying the antiplatelet regimen as a result of the PRU or ARU values led to a 7-fold decrease in the thromboembolic event rate without really leading to a statistically significant increase in the bleeding event. The authors conclude that compared to the standard preparation in patients that demonstrated that they had a high on-treatment platelet response, the modified preparation led to decreased thromboembolic events in coil embolizations on ruptured intracranial aneurysms without increasing the rate of bleeding complications. And they suggest that modifying the antiplatelet preparation based on a platelet function test before coil embolization is a safe and effective strategy. Some of you may be aware that this month in the AJNR, a different paper was also published, which found that platelet testing was associated with worse clinical outcomes in patients that were treated with a pipeline embolization device. This was a retrospective review of 698 patients that were enrolled in the Intrepid registry with unruptured aneurysms that were treated with pipeline, and this registry ran from July of 2008 until February of 2013. The majority of patients underwent some sort of platelet testing, almost 3/4, whereas a minority at about 27% did not undergo any platelet testing. There was no data on whether or nor how the antiplatelet regimen was adjusted according to the results, and there was also no data on which test was used to measure platelet reactivity. The results of that study are summarized in this table, and basically what they found is that between the patients that underwent platelet testing and those that did not go platelet testing, there was a higher rate of multiple pipeline embolization devices that were deployed compared to in the patients that underwent platelet testing as opposed to the ones that did not undergo platelet testing. This was a very concerning result in that all neurologic morbidity and mortality was 8.8% in the patients that underwent platelet testing and 3.2% in the patients that did not undergo platelet testing. There was also a higher rate of intracranial hemorrhage in patients that underwent platelet testing at 2.3% compared to 0% in patients that did not undergo platelet testing. And the all-cause mortality was also higher at 4.1% versus 1.1% in between the two groups. So we have to ask ourselves, what happened in the study? A couple of thoughts on this study, in the Intrepid study. This really represented the early experience among testers, particularly in the US, but also elsewhere in the world. The higher number of pipeline embolization devices that had to be deployed could be a marker for more technically difficult procedures in these patients. And we'll see in our experience how that can lead to worse outcomes. Back then, also, operators were mostly concerned about avoiding thromboembolic complications. And the risk of very low PRU values in the perioperative period was not recognized at the time of the registry. Hence, we were using very high doses of very potent drugs, such as prasugrel and ticagrelor, in patients who were considered clopidogrel hypo or non-responders. And this effectively meant that we were correcting our patients. We were going from hyper-response to a very hyper-response in these patients because the drugs and the doses that we were using were too high. And it wasn't really clear what a safe PRU range was also back then. So even though there is value in looking at the retrospective data in the Intrepid registry, we have to understand that we have to be very careful with the testing. And we also made a lot of dosing changes, quote unquote, on the fly and intervene without waiting to reach the safe PRU range before going ahead and intervening and deploying the pipeline. So what I would say is that if you have performed lots of pipeline procedures without using platelet testing, and you have had no major thromboembolic or hemorrhagic complications, then by all means, you should keep doing what you're doing. Nobody can really tell you that you have to do testing. But if you have had major complications with pipeline, with or without platelet testing, I would ask you to consider please using the PRU testing to guide your Plavix dosing, but also being very careful with the results so that we don't overcorrect patients. And also, when you make a dose adjustment, we have to retest, and if we're making a dose adjustment right before the procedure, we may want to consider rescheduling the patient. Our experience with dual antiplatelet therapy for pipeline procedures has really evolved over the last 4 years. In our first 5 cases that we did, we were following a protocol that came out of Turkey, where we were starting patients 7 days before the embolization on aspirin and Plavix. We were using 325 milligrams of Plavix, a loading dose of Plavix of 300 milligrams, and then a daily dose. And we were performing our VerifyNow test on the day of the procedure. Back then, we were using a target inhibition range of 40 to 200. And for hyperresponders, we were increasing the Plavix dose. And for hyperresponders, we were just decreasing the Plavix dose to every other day. Importantly, we were not rescheduling procedures, and we were also not performing routine VerifyNow tests. Our second case that we performed with pipeline, pre-procedure, the patient had a PRU of 272 after 7 75 milligram Plavix doses and a loading dose. As following our protocol, we doubled the Plavix dose, but we went ahead and undertook the procedure without waiting to retest the patient. This was a technically difficult deployment of a of two pipeline devices, one inside the other, and we require balloon angioplasty to open up the second pipeline device. The procedure time was 97 minutes. On postoperative day number 2, the patient developed a worsening of her baseline left-sided weakness. She had had a previous stroke on that side. And when we performed an MRI, she had a large shower of thromboembolic DWI hits on the side of we had performed the pipeline device. We also tested her at the moment of the MRI, and her PRU was still very high at 292. The fifth case that we did with pipeline showed a pre-procedure PRU of 170 milligrams after only 5 75 milligram Plavix doses. We made no changes to the Plavix dosing, as she was within the range that we wanted her to be. But we again underwent a technically difficult deployment where we herniated into the aneurysm sac, and we had to deploy 5 pipeline devices to complete, to bridge the aneurysm neck. The procedure time in this patient was 222 minutes. The patient was discharged home on the day after the embolization, but on postoperative day number 8, she came into the hospital with the acute onset of headache and expressive aphasia. A head CT was performed, and this demonstrated a left inferior frontal intraparenchymal hemorrhage on the same side of the pipeline. We performed a PRU test at the time of the hemorrhage, and her PRU had decreased from 170 to 2. And this was after 13 daily 75 milligrams Plavix doses. We were lucky that this patient recovered completely from this hemorrhage and came back to being independent. So our first procedures that we performed with pipeline, we had 2 thromboembolic complications, 1 hemorrhagic complication, and our disabling complication was a thromboembolic event that we showed. And this occurred in a clopidogrel hyporesponder who had her clopidogrel dose doubled on the day of the procedure, but we underwent the pipeline deployment with a very high PRU value. We didn't wait for the dose effects to the dose changes to take effect before we deployed the pipeline. For the next 40 cases, we changed our protocol, and where we extended the duration of dual antiplatelet therapy prior to the Plavix dosing to 10 days. We were still using 325 milligrams of aspirin and 75 of Plavix, but we now moved our testing to 1 day before the procedure. Our target PRU range, we moved up to 80 to 200, and for hyporesponders, we decided to switch them from Plavix to prasugrel since we had that major thromboembolic complication. But notice that this prasugrel dose was very high. It came from the cardiology literature. It was 60 milligrams of prasugrel, followed by 10 milligrams of prasugrel daily. For hyporesponders, we started spacing out the Plavix dosing more and more to as much as every 5th day. But we were still not willing to reschedule our procedures as a result of our P2Y12 test. And we did introduce follow-up tests after 10 and 30 days after any dosing change. The next 25 cases went really well, but then we had our case number 33. We have a patient with a PRU of 258 after 10 75 milligrams Plavix doses. As per protocol, we switched to prasugrel with a 60 milligram loading dose the day before the procedure, and then we put her on 10 milligrams daily. The day of the procedure, we retested her PRU, and it came down to 13. We again encounter a technically difficult deployment requiring 4 pipeline devices to be implanted to bridge the aneurysm neck. Our construct fell apart. We eventually finished the case, but the procedure time was 193 minutes. On postoperative day number 10, the patient came back for her routine P2Y12 test follow-up, and it was 0. We had never seen a test like that before, so we repeated the P2Y12 test, and it was 0 again. The patient was asymptomatic and neurologically intact, so we decreased the Plavix, the prasugrel dose to 5 milligrams. Unfortunately, on 4 days later, on postoperative day number 14, the patient developed sudden onset of headache and left-sided hemiparesis. and she came in with a very large basal ganglia hemorrhage on the same side of the hemorrhage, and her PRU was still 0 at that time. The next 40 pipeline procedures that we did, our thromboembolic event rate did go up to 5%, as well as hemorrhagic events, but we still had 2 major disabling complications, both of which were hemorrhagic complications. And again, they were both on clopidogrel hyporesponders who were loaded with prasugrel and underwent the pipeline deployment with very low PRU values. But our complication rates had decreased in the next 40 cases. Then going back to how we were adjusting our protocol for the next 3 cases, we decided to decrease the aspirin dose to 75 milligrams, since we had run into a lot of problems, hemorrhagic complications in patients that were in the 200s, and there was some data from the cardiology literature saying that you could go anywhere from 230 to 240 would be okay. We decided to try 235 as our upper range. We went back to Plavix, double dose Plavix for our hyper-responders, and we didn't make any changes to our hyper-responders. But we were beginning to think about rescheduling our procedures, but we only rescheduled if the PRU was less than 40 or greater than 250 at the time. The 48th case we performed with pipeline, the patient came in with a PRU of 246 after having received 10 daily Plavix doses. For protocol, we doubled her Plavix dose. This was 3 days before the procedure. Unfortunately, we did not retest her PRU because per protocol we were going to be retesting her the following week. We went ahead and undertook the procedure on the planned date without retesting. And we underwent an uncomplicated deployment of a single pipeline device to treat a recurrent aneurysm. The procedure time was only 30 minutes. The patient was discharged home the following day and went home neurologically intact. And we were planning to bring her back on postoperative day number 7 for a routine follow-up. Unfortunately, on postoperative day number 4, the patient was found unresponsive at home. And a head CT demonstrated a massive left temporal hemorrhage on the same side as the pipeline. When we tested her PRU, it had come down from 246 to 10. This really brought us to make us think about what was happening with our patients. Was it the device, or was it the drugs that was doing this to our patients, since we were having lots of complications? So in our first 48 pipeline procedures, we had up to 6 months, we reached a thromboembolic complication rate of 12.5%, and also importantly, a 10% hemorrhagic complication rate. And our disabling complication rate was as high as 10.4%. And most of these complications were hemorrhagic complications that were occurring in our patients. We then looked a little bit further, and as we said, all of this 80% occur in clopidogrel hyporesponders who had undergone changes to the dual antiplatelet therapy regimen without waiting to reach the target PRU range prior to deploying the pipeline. And also importantly, at the time of the complications, 80% of them had markedly decreased PRU values when they had a hemorrhagic complication, or markedly elevated PRU values when they had a thromboembolic complication at the time of the complication. We analyzed further our data, trying to see whether we could correlate the PRU to the risk of any complication as well as disabling complications. And indeed, when we looked at our data, the last recorded PRU value, and we saw that the PRU was less than 60, and we had 9 patients with this PRU value, we were experiencing a 55.5% complication rate, any complication rate, most of which were hemorrhagic. But importantly, we had a 33.3% major hemorrhagic complication rate, disabling complications. When we had a high PRU greater than 240, we had only 2 patients like that. Both patients experienced thromboembolic complications, and one of those patients had a major disabling complication of 50%. And then we found that when we were in that middle range of 60 to 240, Our complication rate for any complication was 10.8%, but importantly, our disabling major complication rate came down to 2.7%. This was markedly statistically significant, and in addition, when we ran a multivariate regression analysis, we found that the only independent predictor of a disabling thromboembolic or hemorrhagic complication up to 6 months in our patients that were treated with pipeline was a last recorded PRU value that was either less than 60 or greater than 240. And we published our results in the AJNR in 2014. Our group has really have to deal with a lot of ICHs after pipeline. And our theory has been that the majority of ICHs that occur after pipeline are due to hemorrhagic transformation of clinically silent perioperative infarctions that occurred at the time of the endovascular procedure. But in the setting of a hyper-response to the P2Y12 receptor antagonist that is administered. To date, we have performed routine MRI examinations on postoperative day number 1 in 40 asymptomatic patients after pipeline procedures. And we're finding that the majority of patients, 80%, have at least 1 or 2 DWI hits. The mean number of hits that we see are 7, median of 3.5. There are some patients that have no DWI lesions, but we have some patients that have up to 48 DWI lesions. The majority of these lesions are punctate less than 5 millimeters. Of those patients that have any DWI lesions, hits, about 45% of them have a very high burden of DWI hits. And we define that as having more than 5 or any hit that is at least 10 millimeters in size. And the predictors of the patients that are going to have a high DWI burden are when we're treating a fusiform aneurysm, when we encounter a technically difficult pipeline deployment, or when we have a procedure time that is prolonged greater than 90 minutes. As an example of a patient with a low burden of a DWI hit after a pipeline embolization, we see that there's a small ipsilateral hit in the occipital lobe in this patient. But there are some patients that will have a shower of DWI hits on the same side that we were working on. Both of these patients are asymptomatic. Our theory is that patients like this that have a high DWI burden when we're done with the procedure are at high risk of bleeding from any of these lesions if the PRU values are low. Our 60S case that we did with pipeline was a patient that underwent the urgent deployment of a pipeline device. She had a symptomatic cavernous aneurysm, and it was opted to give her ticagrelor. Ticagrelor is a very strong drug, but we know that pretty much everybody is going to respond to it. It was a prolonged procedure time of about 100 minutes. And when we performed the MRI the next day, and again, the patient was asymptomatic, there was a high DWI burden. She had a total of 48 DWI hits. As we were examining the images, we noticed, however, that one of the DWI lesions looked a little bit different from the rest. And again, this is an asymptomatic patient. This is a routine MRI on postoperative day number 1. We performed a head CT, and there was a small hemorrhage in the external capsule on the same side of the pipeline. We performed a PRU test at that time, and the PRU was 49, which was lower than 60. We held ticagrelor on postoperative day number 1, and on postoperative day number 2, the patient becomes asymptomatic. Postoperative day number 2 also, the PRU rises to 139. As ticagrelor is a reversible drug, so if you stop giving ticagrelor, the PRU will rise, and it can be fairly quick. The patient was started on Plavix on postoperative day number 2 and postoperative day number 3, but no loading doses were given, and this was just a routine Plavix dose. We were planning on checking the PRU value on postoperative day number 4. But unfortunately, early that morning on postoperative day number 4, the patient developed a sudden onset of severe headache and left-sided hemiparesis. And the hemorrhage had enlarged markedly. And when we retested the PRU value, it had gone down to 9. Nowadays, we understand a little bit better that a single Plavix dose can have a marked effect on the PRU value in patients, susceptible patients, particularly when they are in the perioperative period immediately after anesthesia. The last 54 flow diversion procedures that we have done at Abbott, we have been able to bring our disabling complication rate to 1.9%, and that is that one hemorrhagic complication that we had in a patient that underwent an urgent or emergent pipeline deployment in a patient with ticagrelor. And again, when the complication occurred, the patient had a very low PRU value. Our hemorrhagic, we've also had other hemorrhagic complications, but they have not been disabling. Comparing our first 48 pipeline procedures to a second flow diversion procedures, we have similar rates of any thromboembolic complications. And again, this includes minor complications like TIAs or minor strokes. Our hemorrhagic complication rate has decreased to 3.7%, but importantly, our disabling complication rate, where patients are not able to live independently anymore, has gone from 10.4% to 1.9%, and the majority of them, in our experience, have been hemorrhagic. We're collecting our data, and we are, as of now, we can say we have a trend, but we have not reached statistically significance in our case series as of yet. So when we look back at the data again of all of our flow diversion procedures, and we've done 102, and we look at them by PRU values, again, we can see that when we have a low PRU of less than 60, we're taking about a 36% hemorrhagic, major hemorrhagic complication rate. When we have a high PRU of greater than 240, we have about a 50% major thromboembolic complication rate. And when we manage to keep our patients in that safe intermediate range of 60 to 240, and we've managed to do this in 89 patients, we have a 14% any complication rate, but again, this includes TIAs, groin hematomas, any kind of complication that may be related to the antiplatelet therapy that we're giving our patients. But importantly, our major disabling complication rate has gone down to is 1.1%. And this is markedly statistically significant. When we add in the Stent-Coil procedures that we have performed, in addition to the pipeline procedures that we have performed since VerifyNow became available in our hospital, when we did the first 62 procedures, most of which were pipeline as well as some coil embolizations, we were dealing with a 8.1 disabling complication rate. But in the last 100 procedures that we have done, since we really stopped and said that we were going to use the PRU values to guide whether or not it is safe to intervene, we have had a 12% thromboembolic complication rate, any thromboembolic complication rate. Again, a lot of these are TIAs or very minor strokes. Our hemorrhagic complication rate is 3%, and our disabling major complication rate is only 1%, and it has been that one hemorrhagic complication that I showed in the patient that where we performed deployment of the pipeline urgently. And this is statistically significant, the difference between the two groups. When we look at all of these patients as well, and by PRU values, again, we see that when we have a PRU less than 60, we're looking at about a 20% major hemorrhagic complication rate. When we have a PRU of greater than 240, we are taking about a 20% major thromboembolic complication rate. And when we manage to keep our patients in that 60 to 240 range, we do have a 13.9% any complication rate. Again, groin hematomas, minor strokes, or other sorts of GI bleeding sometimes. But of a disabling complication, with the rate is 0.7%, and that is that one hemorrhagic complication. That is one hemorrhagic complication. Again, markedly statistically significant. So we've looked further at our experience in our patients, and in our particular patient population, you can see we published our experience of 100 patients that underwent endovascular treatment of brain aneurysms, and since we test everybody now, and we can see that we're really dealing with a normal distribution of PRU values. However, our curve is somewhat weighted towards the hyperresponder patients. We also early on recognized the fact that as you gave patients Plavix for a longer period of time, the PRU values tended to decrease. And importantly, some of those patients would have marked decrease in PRU values. In the same cohort of 100 patients, we were able to estimate that when we had a hyper response to Plavix, and we defined that as a PRU of less than 60, the risk of a major hemorrhagic complication was 11%. Again, a low PRU doesn't mean that your patient is going to bleed for sure. Indeed, most patients will not bleed, but an 11% major hemorrhagic complication rate is very high, and it's something that we can definitely avoid. When we have a PRU of greater than 240, we found that in our patients, we were taking about a 60% risk of a thromboembolic complication. And when we were in this intermediate range of PRU less than 240 and greater than 60, we had a 3.6 thromboembolic complication risk and no major hemorrhagic complication risk. And both of these had significant p-values. This was published in the Journal of Neurointerventional Surgery in 2014. So right now, we've really rearranged our practice to follow the PRU values. We recognize that there can be some schedule constraints, and because of that, we're giving ourselves a little bit more time from the start of dual antiplatelet therapy to when we have the planned intervention. So currently, we are starting our patients 17 days before the planned embolization. We're starting everybody on a baby dose of aspirin, 81 milligrams of aspirin, and a standard dose of Plavix. But we are performing the first VerifyNow test after the 10th Plavix dose, and that is 1 day, as well as 1 day before the procedure and on postoperative day number 7. So at a minimum, we will perform 3 VerifyNow tests in our patients. Our target PRU range, we are using the ADAPT DES range, which is really the safest range of 95 to 207 up to postoperative day number 30. And then after we cross that threshold of postoperative day number 30, we relax the range to 60 to 240. We'll go into the regimen for hyperresponders a little bit later. For hyperresponders, we are using Plavix every other day, every third day, or more and more we are using the Plavix suspension. We will reschedule the procedure, even if it's a Stent-Coil or a simple coil embolization, if the PRU is less than 60 or greater than 207 the day before the embolization. And we are performing a routine VerifyNow, follow-up VerifyNow. Our aspirin with 81 milligrams, and we assess the aspirin therapy response with VerifyNow aspirin assay. And if the ARU is greater than 550, we increase the dose to 325, but we do not perform any further testing. For Plavix, we perform the PRU test after the 10th Plavix dose, which is 1 week before the procedure. And we think this is very important. We give ourselves 1 week so that the dosing changes, to give time to the dosing changes to take effect before we retest the day before the procedure. These are the dosing schedules for Plavix that we have been following. We start everybody on 75 milligrams daily up to postoperative day number 30, and that is the most high-risk period, the perioperative period. If the PRU is greater than 207, we go back 1 step, meaning that if you are on 75 milligrams of Plavix daily, we will increase the dose to 150 milligrams of Plavix daily. We will test you again the following week, and if the PRU is again higher than 207, then we will add cilostazol, 100 milligrams BID, if it is appropriate for the patient. If the patient has heart failure, we cannot use this drug. We decided to try cilostazol before switching patients to prasugrel or ticagrelor, just to be more in line with the randomized controlled trial out of Korea. Of the patients that are hyper-responders to Plavix, if the PRU is 40 to 94, we will decrease the Plavix dose to every other day. And as the PRU decreases, is lower and lower, we would decrease the Plavix dosing. So that if you have a single-digit PRU or a 0 PRU, you will automatically go to our Plavix suspension, anywhere from 2.5 milligrams to 10 milligrams daily. once we cross that threshold of postoperative day number 40, we relax a little bit the parameters, and then we use 240 as our upper range of the acceptable range, and then also we go down to 60 for our lower range of the acceptable range. But we use the same dosing schedule. We perform the second VerifyNow test no earlier than 1 day before the procedure, and we will reschedule the procedure if the PRU is greater than 205 or less than 60 that day. We perform a routine VerifyNow test on postoperative day number 7 on everybody, as well as 30 to 40 days after initiation of Plavix administration if we haven't made any changes to the dose, as well as 7 to 10 and 30 to 40 days after any dose adjustment. And if patients present to us with any symptoms, including abnormal bruising or bleeding or any focal neurological deficits, we will also test them right at the time that they're having the symptoms. We avoid urgent or emergent stent or pipe or flow diverter deployment whenever possible, because things are a lot more complicated then. The dose adjustments really work in our experience. When we double the Plavix dose from 75 to 150 milligrams, we can expect about a drop in the PRU of about 88 PRU, and 82% of those patients will be within the acceptable range. And also, as we're using more and more the Plavix suspension, we're seeing that we can get our patients from very low PRU values to the range with a very high degree of success, 81%. To date, we have had one Plavix hyporesponder who experienced a major hemorrhagic complication as a result of doubling the dose, and I showed you that case where we did not retest the patient before the procedure. But really, we have not had any hyperresponder that has had a disabling thromboembolic complication as a result of lowering the Plavix dose. This is our experience with the success of our protocol. This is the first test on after the 10th Plavix dose. We can see that patients are all over the map. Then when we 29 are outside the range, when we of those that were in range pre-procedure remain in range at 10 days, at 17 days. Okay, so some of them did fall out of the range. Okay, without making any dose adjustments. But after the initial dose adjustment, we were able to get 93% of the patients into the target PRU range that we wanted using the protocol that we showed. So overall, 88% of patients were in range at 17 days. However, we have noticed now that very consistently our patients are experiencing a drop of PRU values in the immediate postoperative patients. 64% of patients who were in range pre-procedure, we're now seeing that there's a delayed conversion to a hyperresponse anywhere from 7 to 14 days after the surgery. So in conclusion, VerifyNow is a reliable assay for platelet function testing. A high PRU value increases the relative risk of thrombosis. It doesn't mean that you're going to have a thromboembolic complication, but it does increase the risk of thromboembolic complication occurring. A low PRU value increases the relative risk of bleeding. Again, it won't make you bleed, but if you have something that if you have a lesion that can start to bleed, it will bleed more because you will have no platelets to contain the bleeding, no functional platelets to contain the bleeding. We now have level 1 evidence is now available that demonstrates that modifying the dual antiplatelet therapy regimen for clopidogrel hyporesponders can decrease the rate of thromboembolic complications without increasing the risk of the rate of hemorrhagic complications for cerebral aneurysm treatment. And we need more prospective studies to determine if modifying the dual antiplatelet therapy regimen for clopidogrel hyporesponders can decrease the rate of hemorrhagic complications without increasing the rate of thromboembolic complications. We have to recognize that there is wide and dynamic variability in patient response to the P2Y12 receptor antagonists that we administer. And in our experience, up to 2/3 of patients are experiencing a delayed conversion to clopidogrel hyperresponse in the early postoperative period. And this could be related to some of these perioperative bleeds that some operators have experienced. We're not 100% sure, but we think that it may be related to effect of general anesthesia on the hepatic metabolism of Plavix. So answers to the questions that we had regarding P2Y12 testing. Which test to use? I would say that VerifyNow is a very reliable test. Importantly, where to perform it. I would very strongly suggest that this test belongs in the hospital's core laboratory, not in the angio suite. It needs to have the proper controls and testing to make sure that you get reliable results. We trust our P2Y12 results in our hospital's core laboratory. When to do it? I would say that 1 day pre-op and 7 to 10 days after any dose change at a minimum. But I would also recommend to do one test 1 week pre-op to give yourself time to adjust the dose if you're going to do that, so you don't have to reschedule the case, as well as 1 week post-op if you're using general anesthesia as well. What is a safe range? I think 95 to 207 is the safest range, and we are now following that range up to postoperative day number 30. But a 60 to 240 range, which we've been using for close to 4 years now, is an acceptable range. And now we're following that range after postoperative day number 30. How do you manage clopidogrel hyporesponders? I would say first, we recommend increasing the Plavix dose to 150 milligrams daily. If that doesn't work, then you could consider adding vilostazol of 50 to 100 milligrams BID, but only if it's appropriate for the patient. If not, then we can switch the patient to prasugrel or ticagrelor whenever needed. I would say that please avoid increasing the Plavix dose or switching patients to prasugrel or ticagrelor and intervening immediately, as the PRU may drop significantly after you change the regimen. How do you manage clopidogrel hyperresponders? I would decrease the Plavix dose to every other day or every third day, and definitely think about using a Plavix suspension daily for patients who are super hyperresponders, and those are the ones that have PRUs less than 10. And in those patients, we perform monthly PRU testing. And I would say that you should avoid intervening with very low PRU values, that there is a real and high risk of bleeding, and not only in the brain. And minimizing the risk of perioperative complications for flow diversion and stenting procedures, I believe that will enable us to continue to expand the frontiers of endovascular aneurysm treatment. Thank you very much.
Thank you, Dr. Delgado, for sharing your experiences with us today in the webinar. And thanks to all the attendees for joining us today. We look forward to you joining Accriva Diagnostics for future webinars. For additional information, please visit accriva.com. Thanks to all of you. Good day.